Welcome to Pulse and Pressors, where critical care gets crystal clear. Today, we're diving into the pharmacology of lidocaine, a drug that blurs the line between anesthetic and antiarrhythmic, holding a unique position in both the operating room and the ICU. Lidocaine is an amide-type local anesthetic and a Class YB antiarrhythmic. In critical care, it's used for rapid suppression of ventricular irritability, particularly following myocardial infarction or cardiac surgery, without impairing atrioventricular conduction. Lidocaine, mechanistically, blocks voltage-gated sodium channels during their inactive state, particularly in depolarized or ischemic tissue. This shortens the action potential and reduces automaticity in ventricular myocardium while leaving atrial conduction largely intact. In neurons, this blockade prevents sodium influx, stabilizing the membrane and producing local anesthesia. Pharmacokinetically, lidocaine acts within seconds and has a short half-life of roughly 2 hours. Hepatic metabolism via CYP1A2 and CYP3A4 is saturable, meaning accumulation occurs rapidly in hepatic congestion, heart failure, or after bypass. Its context-sensitive half-time increases with prolonged infusion, which is crucial during postoperative weaning. Hemodynamically, lidocaine is stable. It generally maintains vascular tone, with only mild decreases in heart rate and blood pressure at higher concentrations. These effects make it a safe antiarrhythmic for postoperative patients where myocardial oxygen demand must remain low. The standard bolus is 1 to 1.5 milligrams per kilogram, followed by an infusion between 1 and 4 milligrams per minute. Clinicians titrate to rhythm stabilization while maintaining adequate mean arterial pressure. Toxicity typically begins when serum levels exceed 6 micrograms per milliliter. Adverse reactions include early neurologic symptoms such as dizziness, tinnitus or paresthesia, progressing to seizures and cardiovascular collapse at higher doses. Immediate intervention includes airway support, benzodiazepines for seizure control, and lipid emulsion therapy for severe toxicity. In the cardiac population, lidocaine's interactions with beta blockade can enhance bradycardia, and its use in aortic stenosis requires careful monitoring to avoid hypotension. It remains neutral on pulmonary pressures, making it a good choice for patients with pulmonary hypertension or right ventricular strain. Lidocaine's clinical efficacy depends heavily on the type and origin of the arrhythmia. It's crucial to differentiate between ventricular and supraventricular sources before reaching for the medication. For ventricular tachycardia, particularly monomorphic VT, arising in the setting of myocardial ischemia or post-cardiac surgery, lidocaine is highly effective. Its sodium channel blockade preferentially targets depolarized, ischemic myocardium, the tissue most prone to reentry and ectopy. This selective action explains why it's a cornerstone for ischemia-related ventricular irritability and for suppression of ventricular ectopy following reperfusion. In polymorphic VT, lidocaine's role becomes less consistent. If the arrhythmia stems from ischemic irritability, it may help. However, in repolarization-related polymorphic VT, such as torsades de pointe, it can worsen electrical instability and should be avoided. For ventricular fibrillation, lidocaine remains an accepted adjunct after defibrillation and epinephrine. It stabilizes cell membranes, dampens automaticity, and helps prevent recurrent VF after successful shock conversion. In the case of frequent PVCs, particularly when symptomatic and ischemia-driven, lidocaine can provide control by reducing ventricular irritability. However, it should be avoided in bradycardic or sick sinus patients, where suppression of escape beats could precipitate a systole. Lidocaine is ineffective against supraventricular tachyarrhythmias, including atrial fibrillation, flutter, and narrow complex SVTs, because its mechanism is limited to ventricular tissue. Using it in these cases adds hemodynamic risk without therapeutic benefit. There have been very rare reports of a peculiar form of non-reentrant atrial tachycardia, not V-Fib or a flutter, that is sensitive to and can be terminated by lidocaine. However, this is an unusual, highly specific form of the arrhythmia and is not part of the standard clinical indication for lidocaine. Finally, in idioventricular rhythms or slow ventricular escape rhythms, lidocaine is contraindicated. Suppressing the last remaining pacemaker in a bradyasystolic patient can lead to complete electrical silence. Likewise, it should never be used in torsade de pointes, where magnesium is the treatment of choice. After cardiopulmonary bypass, systemic inflammation expands its volume of distribution and reduces protein binding, resulting in lower plasma levels initially, but prolonged elimination. Therefore, the infusion rate should be reduced by 50% in the first 12 hours postoperatively to avoid delayed toxicity. Absolute contraindications include severe sinoatrial or atrioventricular block without pacing, amide hypersensitivity, and wide complex tachycardias like Wolff-Parkinson-White. 3 high-yield pearls. First, lidocaine selectively targets ischemic tissue, making it ideal after infarction or bypass. Second, hepatic metabolism saturates quickly. Adjust for low-output states. And third, its toxicity can mimic neurologic emergencies, so always consider lipid rescue early if instability develops. Screenshot this slide for a quick reference. This is Pulse and Pressors, reflecting on the marvels of the human body. Subscribe to stay sharp.